Good morning. My name is Dr. Cynthia Magro. I'm the Director of Dermatopathology for Weill Cornell Medicine. Welcome to our interesting case presentation. So, the case today is that of a 69-year-old male with a 2-year history of progressive induration, hyperpigmentation of the anterior chest and upper back. He had also experienced thickening of select digits. Part of his investigations revealed that he had antibodies to Rho. This clinical image shows this indurated, hyperpigmented patch involving the dorsum of the hand, and he had similar lesions on the anterior chest and the upper back. So a punch biopsy was performed, and so what do we see here? Well, I think there is this discrete area in the biopsy where there is clearly fibrosis. I would say that the collagen bundles are of wider caliber, the interstitial spaces are substantially diminished, and note how the fibroplasia is really involving the mid and deeper dermis with relative sparing of the more superficial dermis. And this is a higher magnification showing that this fibrosing reaction is what I would describe as hypocellular. Oftentimes with fibrosis, especially when it's related to a scar, there is an influx of fibroblasts, and so it tends to be a hypercellular fibrosing reaction. Well, in this particular case, it is really hypocellular. And again, this is just another high-powered view showing the collagen bundles being of wider caliber with diminution of the interstitial spaces, and again, at disparity with the extent of fibrosis is the relative lack of cellularity from a fibroblast perspective. As well, there is a smattering of lymphocytes and plasma cells, so there is an element of inflammation. And I do believe that there is probably a component of ductal and glandular dropout and atrophy of the equine coil. Now, within that zone of fibrosis, these fibroblasts, which were producing all this collagen, albeit not increased in number, had a very distinctive phenotype. And what was that phenotype? Well, normally a CD34 stain will highlight fibroblasts in the dermis. But in the setting of an autoimmune sclerodermoid tissue reaction, those fibroblasts develop a pro-collagen phenotype, which is hallmarked by a lack of staining for CD34, as noted here, within that zone of fibrosis, but with a paradoxical or reverse expression of smooth muscle actin. So normally, smooth muscle actin is not expressed in fibroblasts, but when you have that pattern of a loss of CD34 with acquisition of smooth muscle actin staining, that is a cardinal hallmark of a pro-collagen phenotype. So to summarize then, what did this biopsy show? It showed a deeper seated paucicellular pattern of hyalinizing fibrosis, whereby there was this very distinct pattern phenotypically with respect to the fibroblasts within that zone of fibrosis, namely fibroblasts that showed a loss of CD34 and acquisition of smooth muscle actin staining, typical for a pro-collagen phenotype that we see in certain autoimmune fibrosing disorders. This was the direct immunofluorescence, which was really quite fascinating. It showed, this happens to be IgG, and the IgG is decorating the nuclei of keratinocytes as well as the nuclei of endothelial cells. And typically when one sees IgG and components of complement activation decorating keratinocytes, there is a very strong association with an antibody to an extractable nuclear antigen like Rho, like LAW, Smith, and RMP. And of course, we know that this patient has antibodies to Rho, and in this particular case, it seems to be targeting, the antibody seems to be targeting epidermal keratinocytes as well as the microvasculature. So I think the diagnosis in this case is scleroderma in association with anti-Rho antibodies, and it is reasonable to state that it's photosensitive. This patient had a very distinct rash. It was noted to be on the V of the anterior chest and the upper back, as well as involving the hands. So it is this very peculiar presentation of scleroderma being in the context of a photosensitive variant. So there are two broad categories of scleroderma. We have skin-confined scleroderma, and it falls under the designation of morphea, or you have systemic sclerosis, where you have cutaneous and internal organ involvement. Morphea has various subcategories. like guttate, plaque, segmental, generalized, and subcutaneous. This would be a patient who has generalized morphea and also had concomitant features of lichen sclerosis and atrophigus, and this is more of a circumscribed plaque type of morphea, possibly even with the isotopic vitelliginous component, given the hypopigmentation, or perhaps there's some overlap with lichen sclerosis. So what about this patient? Did this patient have generalized morphea, or is it possible that he had diffuse systemic sclerosis? Well, I think in this particular case, at this point in the patient's presentation, we don't know that he has internal organ involvement per se, but what is interesting is that he does have evidence of sclerodactyly, which we typically see in diffuse systemic sclerosis and is usually absent in generalized morphea. Now, the other interesting point is the fact that he's anti-Rho positive. In general, anti-Rho positivity in the setting of scleroderma is seen in patients with diffuse systemic sclerosis. So I think that between the sclerodactyly and the fact that he's anti-Rho positive, my belief is that this patient probably has anti-Rho positive diffuse systemic sclerosis. But at the moment, we don't know that he has any defined internal organ involvement. So scleroderma is not considered a photosensitive disorder per se. Like, there's certain collagen vascular diseases that are absolutely photosensitive: systemic lupus erythematosus, mixed connective tissue disease, and dermatomyositis. So the idea of photosensitive scleroderma is definitely not an established one, but I think in this case there could be an explanation for it. So number two, a subset of patients with scleroderma, they do have anti-Rho antibodies. Now, when these patients have anti-Rho antibodies, it is associated with a higher incidence of interstitial lung disease. And we will talk about interstitial lung disease in our general discussion on systemic sclerosis. And that is likely attributable to an overexpression of Rho in the septal capillaries, exactly mirroring the role of anti-Rho in the evolution of idiopathic pulmonary fibrosis. That is to say, some patients with IPF actually have select antibodies. They could be scleroderma antibodies, they could be antibodies to RMP. And probably those antibodies are key in eliciting capillary injury in that setting. But also, when you look at patients with pulmonary fibrosis in the setting of systemic lupus, many of those patients, I would say the majority of those patients who have SLE with pulmonary fibrosis, they do have anti-Rho antibodies. So what about the role of anti-Rho and the fact that this patient has developed a scleroderma picture that is photosensitive? Well, one could postulate that the Rho antigen in keratinocytes and in the dermal endothelial cells are displaced to the surface with light exposure, potentially accounting for the inherent photosensitivity and therefore mimicking the pattern of photosensitivity seen with anti-Rho positive systemic lupus or anti-Rho positive subacute cutaneous lupus. And of course, when you go back and look at the immunofluorescent image that I showed you, that antibody was being preferentially deposited in epidermal keratinocytes and in the microvasculature to potentially support this espousal. So the more classic photosensitive sclerodermoid disorders are mixed connective tissue disease, where you have overlapping features of lupus, dermatomyositis, and scleroderma, and they have anti-RMP antibodies. Sclerodermatomyositis, which is associated with anti-Ku and anti-PMSCL antibodies, and then sclerodermic presentations of porphyria. And this was a case I had several years ago of a patient with very classic PCT, and you can see these discrete scar-like milia, but also he has supervening diffuse sclerosis. So he actually had sclerodermic porphyria cutanea tarda. Well, with respect to systemic sclerosis, there are really two broad categories. One is diffuse systemic sclerosis characterized by multi-organ involvement, including the skin, lung, GI tract, and kidney. The other is limited systemic sclerosis, which was formerly designated as CREST. And the hallmarks are calcinosis cutis, which is really a dystrophic calcification, Raynaud's phenomenon, esophageal involvement, sclerodactyly, and telangiectasias. So what are the criteria? I'm just going to turn this heater off here. What are the criteria for diagnosing systemic sclerosis? Well, I think you have to remember that patients with scleroderma, systemic sclerosis, be it in the context of that limited or the diffuse variant, almost invariably have antibodies in their blood. And so what are these antibodies? Well, the anti-topoisomerase 1 antibody is also referred to as anti-SCL. That is a hallmark of diffuse systemic sclerosis. The anti-RNA polymerase 3 antibody, also diffuse systemic sclerosis. The anti-centromere antibody, that is actually quite specific to CREST or limited systemic sclerosis. The anti-BMSCL antibody, which is a nucleolar antibody, it's rarely seen in diffuse systemic sclerosis and more commonly a marker of sclerodermatomyositis, which, as I discussed, is an interesting overlap between scleroderma and dermatomyositis and is one of those photosensitive sclerodermoid-like entities. So what are the cutaneous findings in systemic sclerosis? Well, obviously there's skin thickening, including the thickening of the digits, which is your sclerodactyly. Because scleroderma is really a vasculopathy, or at least a vasculopathy is an intrinsic aspect of the pathology and pathophysiology of scleroderma, it is common to see nail fold capillary abnormalities, capillary dropout, capillary ectasia, and because of the microvascular disease, there will be ischemic changes in the digits, heralded by periungual ulceration, frank digital infarcts. The fibroplasia leads to narrow mouth aperture. Telangiectasias are characteristic. Raynaud's phenomenon, where there is this characteristic vasoconstriction with cold exposure, but sometimes without cold exposure, leading to blanching of the fingers and joint contractures. And so this is a typical patient with scleroderma, and note the telangiectasias and the narrow mouth aperture leading to this sort of pinched faces. This is a patient who has that profound vasoconstriction of the digits to lead to this blanching, and that is Raynaud's phenomenon. This particular patient has very puffy looking hands, but there's clearly evidence of sclerodactyly, and again, because of the microvascular disease, and I will discuss its basis, the patient also has developed or had developed, this is actually from an autopsy I had many years ago, had developed digital infarcts. And this particular patient probably has a combination of some element of digital pallor or Raynaud's phenomenon, along with joint contractures, and the dyschromia that you're seeing on the skin, that corresponds to areas of actual sclerodermoid fibrosing change in the skin. What about the gastrointestinal involvement? Well, these patients develop motility problems. There is this fibroplasia also affecting the gastrointestinal tract, so they do have dysphagia. You can get compensatory esophageal dilatation that is evident on radiographic imaging and even CT scans. What about the lung disease? Well, the lung disease is very distinctive. It will show evidence radiographically of fibrosis, pulmonary fibrosis. And these patients can have an open lung biopsy, which will show pulmonary fibrosis. It can actually define a pattern that's very similar to idiopathic pulmonary fibrosis, and we'll talk about that momentarily. And the fibroplasia is within the interalveolar septa and results in impairment of oxygenation, and the hallmark of that impaired oxygenation will be a reduction in the diffusion capacity. In addition, the antibodies that target the endothelium that we see in scleroderma can target the endothelium of larger blood vessels of the lung and lead to pulmonary hypertension. So let us now address the pathology and pathophysiology of scleroderma. Well, the cardinal hallmark of scleroderma, whether it's morphia or systemic sclerosis, is fibrosis. There is a lot of collagen deposition. It's not that the fibroblasts are increased in number, but the fibroblasts that are present are potent inducers of matrix production. So in this particular field, this is actually a biopsy of a patient with systemic sclerosis, and there is relative preservation of adnexal structures, hair follicles, and eccrine coil. But note, in the deeper dermis, there is definitely fibrosis. The collagen bundles are wider, there are diminished interstitial spaces, and it is highly characteristic in scleroderma for the fibroplasia to really start in the deeper aspect of the skin, including the subcutis. And so here, the superficial dermis is relatively uninvolved, but you do have this characteristic deeper-seated fibroplasia to define a more incipient expression of systemic sclerosis. And this is a much more advanced lesion of systemic sclerosis, where at this point the fibroplasia is basically pandermal. And again, note the diminished interstitial spaces. It is hypocellular, but with a paradoxical abundance of collagen. And at this point, the adnexal structures are largely lost. So in scleroderma, just to summarize, the fibroplasia starts in the deeper part of the biopsy and then becomes eventually pandermal. And with progressive fibroplasia, you do have adnexal dropout, which is certainly very well exemplified by this particular image over here. Now, what about the fibroplasia? Why do we have fibrosis? Well, a very critical aspect is fibroplasia induced by anoxia due to microvascular disease that is of immune-based etiology. This is an immunofluorescent sample of skin, and this is a blood vessel. And what you're seeing is granular deposition of IgG on endothelium, proving, if you will, that this patient has anti-endothelial cell antibodies as the impetus to vascular injury, which in turn will trigger fibrosis. So again, we have the vascular anoxia theory, whereby local tissue anoxia, due to these anti-endothelial cell antibodies, will be a potent inducer of a pro-fibrogenic pathway that becomes very upregulated with an anoxic microenvironment, which is the TGF-beta pathway, as well as upregulation of platelet-derived growth factor, which will be critical stimuli to the elaboration of collagen by fibroblasts. And this is a very interesting collage from a patient with systemic sclerosis, and this is actually in the fat. And there is some hyalinizing fibrosis in the fat, and what is particularly fascinating here are the blood vessels are devoid of endothelium, and they're devoid of endothelium because the endothelium has been damaged by anti-endothelial cell antibodies. And in this particular case of systemic sclerosis of the skin, so we have a skin biopsy in a patient with systemic sclerosis, you can actually see that the endothelium is frankly necrotic, and with exposure of type 4 collagen, you get activation of the clotting pathway, leading to this thrombogenic vasculopathy. And of course, this profound microvascular disease creates that anoxic environment, which is the stimulus to fibroplasia. And some years ago, we did a number of papers addressing the role of anti-endothelial cell antibodies in the pathogenesis of pulmonary fibrosis in patients with scleroderma. And what we found is that we took their blood and incubated their blood with generic endothelial cells. We could, and applied a fluorescinated human anti-IgG, we could actually document the presence of anti-endothelial cell antibodies. And so here you have the generic endothelial cell incubated with the patient's serum, you have a fluorescinated human anti-IgG, and all the endothelial cells are lit up basically. We also took their serum and did Western blot studies, and you can see that there are multiple lines of immunoreactivity to these endothelial cell lyses. So there's no question that in scleroderma, there is a critical role for anti-endothelial cell antibodies in the propagation of the microvascular disease, which in turn is the impetus for upregulating the TGF-beta pathway, which is a critical event in causing the fibroplasia of the skin and other organ systems. So let's look at the lung. This is actually an image of lung, believe it or not. And these are interalveolar septa. These are alveolar spaces, and it's not healthy looking at all. The septa would not be able to oxygenate. There's collagen deposition in the septa with these areas of vascular dropout. This pink material is fibrin, and as well they're red blood cells. So there's clearly evidence of microvascular injury. It's a posse-inflammatory capillary injury phenomenon, very characteristic for the morphology that we see when there is antibody-mediated endothelial cell injury. So we have a posse-inflammatory microangiopathy, probably due to antibodies, leading to vascular compromise, which in turn will trigger fibrosis because of the anoxic microenvironment within the interalveolar septa. So this shows the combination of the microvascular injury of immune-based etiology and the fibroplasia as a response to the anoxia. And probably because they have a deficiency in endothelial progenitor cells, these blood vessels that are damaged with antibodies will eventually disappear, which is how you end up with vascular dropout. And you could imagine that if you had pulmonary function studies, the diffusion capacity in a patient who has a lung biopsy, it looks like that would be very, very diminished, because it would not be possible to really oxygenate the lung with this degree of disease. Now, this is another image from one of my studies from years ago, and this is actually a septa, and this septa essentially is necrotic, basically. The microvessels that are coursing through it are lined by necrotic endothelium or devoid of endothelium, and with that you have activation of the clotting pathway. So we have a septa with no viable endothelium and thrombosis, which will then be replaced by a scar. Now, this is a direct immunofluorescence sample from a lung biopsy I interpreted years ago, and it shows a very characteristic finding in scleroderma lung, which is that the endothelial cells that line the septal capillaries are lit up, and they're lit up in a nucleolar fashion. So this is very typical for an anti-nucleolar antibody. And patients with scleroderma who have scleroderma lung or pulmonary fibrosis in the setting of scleroderma oftentimes have antibodies to SCL70 or topoisomerase, and that is a nucleolar-based antibody, and that is likely the basis of this anti-nuclear antibody pattern on the direct immunofluorescence sample. And as I was mentioning, when you have the immune-based capillary injury, the capillaries disappear, and the anoxic environment will lead to the deposition of collagen. And here you have this microangiopathic fibrosing pattern of pulmonary fibrosis. So the septa, although they're well defined and you see alveolar spaces, they're really not capable of oxygenation because there are no blood vessels, there are few blood vessels or no blood vessels coursing through them, and instead the septa have collagen. So for example, if you look at this septa, it is, this particular portion of the septa is devoid of blood vessels and has collagen. This part of the septa actually still has blood vessels and could oxygenate. But there's no question that this pattern of septal fibroplasia with vascular dropout would lead to severe lung impairment, which from a pulmonary function perspective would certainly be hallmarked by the reduction in diffusion capacity. So the anoxia theory for promoting fibrosis is absolutely an established one in scleroderma, but it isn't the only basis of the excessive fibrosis that we see in the skin and other organ systems in the setting of systemic sclerosis. The platelet-derived growth factor is a potent growth factor for mesenchymal cells, especially fibroblasts. Enhanced expression of PDGF beta receptor protein is documented in scleroderma tissue. Enhanced PDGF expression can be stimulated by certain autoantibodies, and also, again, linking with the microvascular injury concept, the fibrin deposition that occurs when you do have these antibodies damaging the microvessels can be an actual stimulator for the platelet-derived growth factor, which in turn will stimulate the fibroblasts to produce collagen. Well, it's very interesting to note that probably the ultimate basis of the diseased fibroblasts in the scleroderma are actually derived from the bone marrow. So the fibroblasts that migrate into the skin and produce all that collagen in the setting of scleroderma are referred to as fibrocytes. And those fibrocytes are really of monocytic lineage. And these precursor cells to the dermal fibroblast, which again is derived from the bone marrow, they characteristically express CD34. In scleroderma, the CD34 positive fibrocytes, which are a less potent form of collagen producing fibroblasts, they're sort of a precursor phase, they're definitely diminished compared to normal controls. And in turn, smooth muscle actin expression by fibroblasts is increased in scleroderma. So the fibroblasts that are in the skin derived from these circulating fibrocytes have this engineered pro-collagen phenotype characterized by smooth muscle actin expression and loss of CD34. So a profibrotic state is favored when an immature CD34 positive fibrocyte, which again is really ultimately derived from monocyte stem cells in the marrow, differentiate into this potent pro-collagen fibroblast, which is a fibroblast that expresses smooth muscle actin and does not express CD34. So can we target fibrocyte differentiation? Can we target these cells of marrow origin that migrate to the skin and become these pro-collagen producing fibroblasts? And the answer is yes. These monocyte-derived cells are actually quite malleable. So transforming growth factor beta drives fibrocyte to myofibroblast. In other words, the myofibroblast is that pro-collagen fibroblast. Through the SMAG1 pathway, the drug imitamab inhibits fibrocyte differentiation, likely through its inhibitory effects on SMAD1 via PDGF. And when we were doing our imatinib studies, we found that patients who had biopsies showing negative CD34 and enhanced smooth muscle actin expression could potentially define a patient population that might have some degree of responsiveness to Gleevec. And so this is just a collage of images from that study where you can see that before the administration of Gleevec in this patient with systemic sclerosis, there's no CD34 staining, and in contrast there is smooth muscle actin staining, defining that critical pro-collagen myofibroblastic phenotype that we see in scleroderma patients. But then after the Gleevec, the smooth muscle actin actually becomes markedly diminished to absent, and instead we have acquisition of CD34. So the drug actually caused the fibroblasts to sort of dedifferentiate back into a less collagen producing fibrocyte that express CD34 and without smooth muscle actin staining. So it's really quite fascinating, I think. I added at the end of this presentation a few references that address some of our earlier work on the role of immunofluorescence as a diagnostic adjunct in the interpretation of medical lung disease, the role of autoantibodies targeting the microvasculature in the pathogenesis of scleroderma, as well as pulmonary fibrosis in the setting of collagen vascular disease. And Jessica Gordon and Dr. Spira, they were really the leaders in these studies on utilizing drugs like Gleevec in the treatment of early diffuse systemic sclerosis, and these particular images actually were taken by me, but they were in the context of that study. So that's it. That's the presentation today. It's really to address a novel presentation of scleroderma, photosensitive scleroderma, the classification of scleroderma in terms of morphic versus systemic sclerosis, and to look at the pathology and pathophysiology of scleroderma, whether it is in the context of cutaneous confined scleroderma or systemic sclerosis. And hopefully you learned something, and I thank you very much for your attention.